And I I know this can be sometimes a daunting task, but hopefully we can give you some tools that will help you out with this undertaking. At some point, I'll be in drives today. I'm going to use a demo system so we don't have any concerns about PHI. And so basically, the flow today will be talking about what is panel management, what are some steps you can take to prepare for it. Um, then we'll go into drives and look at the tools. And as Heather said, at any point, if you have a question, a comment, concern, anything you want us to know, just drop that in the chat, and we have a number of people who are monitoring that. And so to start us off, um, here's a question. So, what do you feel your comfort level is with, provider empanelment? So some options are we regularly review this and are actively using the tools. Another option is we've looked at these, but we're not sure how to use them. A third option is I don't know. What is empanelment? You can be unsure. You can have another option in mind. So safe space and looking forward to seeing anybody's responses in the chat so I can better direct this user group. Okay, so we do have one person saying they're not entirely confident, unsure. Okay, not confident. Okay, what is it? Yep. Okay, so we'll start with the basics. Dylan saying that they use the tools but probably could use them better. Okay, great. So what we're going to do is, we're going to level set then and talk exactly about what is panel management. And so let's get on the same page. Before you can start this, you need to define your terms. And that goes for pretty much any performance improvement you're going to try to do. And so when we talk about a panel, we're talking about the patients assigned to a specific provider in your EHR. There are panels that come from your payers if you have any sort of integration or exchanging any data with your payers, but these are specifically those in your EHR. Then there's empanelment. Empanelment, that is going to be the actions you take to assign a patient to a specific provider or care team in your EHR. And for patient-centeredness, we say with sensitivity to patient and family preference. And then there's panel management, which is the ongoing maintenance to ensure the panels work for patients, providers, and the practice. And so again, these are specifically your EHR panels, but the work that we're going to talk about will definitely help you when it comes time to be working on those panels that come from your payers. And then another thing I'll mention while we're still here is that empanelment is not a project that you do with a start and an end date. Like we're going to spend 2 months cleaning up our panels. You might need a period of time to do said cleanup if you haven't been focused on it, or it needs a general overhaul. But panel management is ongoing, meaning it happens every day. And it's everybody's job to make sure that the patients are being reassigned as needed and assigned, when they are a new patient and coming in for the first time. And there are a lot of barriers. So again, if it was easy, everyone would be doing it. But typically, people find that they're getting stuck in one or more of these areas. And so there's a lack of a clear starting point. You want to do it, but you aren't really sure where to start or what the data is telling you. Then there are the patients themselves, and everybody's different. So some patients are more complex in terms of medical or psychosocial needs. Then there are trust and engagement issues. So if a performance bonus or productivity is tied to panel size, sometimes providers will be sensitive about that and push back. So you need to establish trust between physicians or providers and your decision makers. And then, like we just said, this is hard work, and it never ends. And the minute you think you have your panels up to date, they're not, they're already outdated, right? So having some clear policies, procedures, and guidelines can help with this. And then again, as we said, it doesn't end, right? You have to keep going because it is one of those things that is constantly out of date. So some benefits. And why does this matter? So if you're a patient, having a dedicated PCP or care team really helps to create a strong foundation of trust and potentially leads to more open and honest conversations about things that are going on in your life. For a provider, strong empanelment helps streamline the patient care. So you have an established relationship with your patients. You might not have to do as much prep work to understand what the patients are coming in for and what their unique care needs might be. So this can streamline care delivery. And then for your practice in general, it will help to distribute the workload more equitably and help you with understanding demand, supply, using data, and then more predictable costs in terms of maybe avoiding those ED and hospital visits because the patients can actually get in to see their provider. Okay. So Drives has a number of ways that can help you in your empanelment activities. So there are 4 measures we're going to talk about today, as well as a dashboard. And I think all of these things can help you. So for example, usual provider assigned is going to look at how many patients are assigned to a usual provider versus how many are not. Panel size, kind of self-explanatory, but this will be how many patients are assigned to a given provider. Then there's provider continuity. So what is the likelihood that a patient assigned to a given provider gets to see that provider? And also the provider perspective, which is how many of the patients am I as a provider seeing are assigned to me? And then the 4-cut provider to PCP match. So I'll go into what the 4-cut method is in a moment, but that's basically going to tell you if you do need to reassign patients to another provider. And so these are our preparation steps. I'm not going to go into them here. We'll revisit them. But this is what you're going to do first. And then you will be in the action phase. And so that deals a lot with the measures. And so again, we are going to go into Drives. We're going to take a look at these measures. If you want to log into Drives and follow along with me, that's great. And just develops that muscle memory so that you can get to these tools more quickly if you need to. Okay, where do we start? Here's this slide again. First, you're going to find a panel manager. Your panel manager is going to lead decisions about panel management activities in consultation with other key stakeholders, of course, and contribute to policy and workflow development and then standardization of those workflows. This person will actively review and maintain or delegate the size and accuracy of panels, and also will be responsible for training teams and sharing data to get buy-in. And so you do have some examples here on the slide of processes that you would need, how to use the PCP usual provider field in your EMR, and then how to identify patients and use a standardized process to assign them. And so I think our DRVS 4-cut methodology can help with a lot of that. The next thing you're going to do is define appropriate providers and update who can be included in the 4-cut calculation. So here's a summary of what the 4-cut calculation is. Basically, 4 passes through the patients to recommend a provider based on their history of primary care visits. So I'll go through each cut so you can understand this better. So first we have a patient, this is our first cut. This patient has just seen one provider over their last 5 primary care visits. And so DRVS is going to recommend that PCP for the patient. However, we know that a lot of patients don't necessarily always get to see their PCP. And so there may be a couple providers sprinkled in there because their assigned PCP is on vacation or not available. And so in that case, we're going to look for the majority provider and we'll recommend that provider as the PCP. The third cut is who performed the last physical. So in this situation, the patient has, again, they've seen 3 providers and the last physical was performed by this light green provider here. And so DRVS will recommend that provider as the PCP. And then finally, again, no clear majority has seen the light green provider, the dark green provider, the purple provider. We're going to recommend the provider that the patient saw most recently. Any questions about that? And then you'll also see in the details list for, this is the panel match measure, but there's also a panel measure where you can see who is the recommended 4-cut provider. Sometimes it will say no match. And this can be in cases where the patient hasn't had a primary care visit in the past 2 years. Maybe they've been accessing your system to see dental, for example. And it may also happen, thinking about that exact same situation, it may happen if, again, they're seeing a provider regularly, but that provider is not included in the 4-cut calculation. And again, sometimes that's because it is a specialty provider like dental. And in other cases, it's because you would not include a provider who's not considered a primary care provider. So here's a way that you can sort of think about this. So including your physicians, your nurse practitioners, your physician assistants who are considered family medicine or internal medicine and do have a primary care panel should be included. However, most specialists, nurses, medical assistants, and then providers who have left or providers who will be leaving should be taken out of the 4-cut calculation. And so also, too, a lot of times you might have OBGYN providers who are, in a sense, providing primary care. And then if you have urgent care providers, you would need to make your own organizational decision about those types of providers. Because sometimes they can serve in a PCP capacity, but sometimes you might not want them to. And where you're going to go to do this is to the provider admin. So this is data that comes directly from your EHR, from wherever you set up your providers, and populates in the admin section in provider admin. On the right side, over here, you have 2 columns where you can make changes. This one, include and filter, refers to the rendering provider or the usual provider filter that you can add most places in DRVS. And this will clean up that list. So if there are providers who you don't want to be included there, they have left, they will be leaving, for example, you can take them out. You can also create provider groups in the provider admin. And so I've seen lots of places make filters that, provider groups that will show up in that filter for like active PCPs or 2026 UDS providers or dental providers, for example. So you can make those groups to make your filtering more efficient. And then the other one is the four-cut calculation. So again, we just talked about the fact that usually this is restricted to providers who are considered PCPs. And so these columns do not have to match. And I would venture a guess that your four-cut calculation column will have less people checked off in it than your include and filter column. And then the four-cut calculation is measure-based. So that will take the weekend to update, right? So the measures and drives reprocess over the weekend. And so this would need the weekend to refresh. Whereas any of these filter settings would take place immediately. Okay, and then we're going to determine our active patient definition. A lot of times I see that health centers are going based on what the payer considers a new patient versus an established patient. And so on your panel measure, you do have the ability to specify what is your definition of an active patient. And you have choices of 1 year, 1.5, 2, or 3. And then you can't see it here, but you also have the ability to specify any visit, meaning they could have seen other services beside primary care, but you also have the option to restrict it to those primary care visits. And then we're going to try to understand our supply and demand. So I'm not going to go into very specific details about this, but I will show you these tools and then you can utilize them to calculate a panel according to the method that is right for your organization. So the first measure we'll talk about is the interactions per patient. This is going to help you understand your patient's demand for appointments. So you can use this to see the average visits per patient per year. And in this example, you can see that the service line was restricted to primary care. Also, note that the patient interactions can be mapped to be qualifying or not. And so for this example shown here, you can see 2.8 is the result, meaning there were 22,440 interactions divided by 8,123 unduplicated patients. And that results in 2.8 interactions per patient. So this is how many times during this trailing year did the average patient come in for a visit. So again, this is going to speak to your demand, what your patients are, how many times your patients are being seen. Then you have an appointments per day measure. This helps you understand the supply of appointments over a particular period of time. So add any filters that you need. You can do this based on an entire panel of providers, or you can do this for one specific provider, but be consistent. And in this example, what we're looking for is this numerator. So your numerator is going to be the total appointments available during the time period you selected. So in this case, it was trailing year, May 2026. And so this will give you the appointments per day. So you can see that the denominator here, that's your number of days. And you can go into the info snippet anytime you're unsure, but it's going to count it as a day of work when there is at least one appointment on that day. Please be careful with this measure because the numerator counts all appointments regardless of status. So what you could do if you have a lot of issues with errors, for example, or lots of patients rescheduling, etc., you can go into the detail list and look in this column called source EHR status, and you're able to select the appointments that you want to include in the numerator. And so I'll mention again, or perhaps Heather already said it, we'll have these slides available for you, so don't feel like you need to be writing these things down. And then you can use that information to calculate your ideal panel size. There are so many methods to do this. You'll kind of have to think about what works best for your practice. But I'll walk you through the example that we put together here, just as a simple way that you could get a ballpark. And so we're going to look at our practice panel for the time period that we consider patients to be active. In this case, it's going to be 18 months. And then we're going to calculate a target panel, which is our ideal practice panel of unduplicated patients divided by full-time equivalent clinical providers. And again, you'll have to decide which providers count in this, in your panel management. Typically, it's going to be those who are PCPs. This 6,000, that's a number we made up, but you would get that from your organization. Maybe it's your HRSA goal. Maybe it's influenced by some projections from your finance department. But you would need to meet internally to understand how many patients, unduplicated patients, do we need to see this year? And then you're going to divide that by the number of full-time equivalent providers that you have. In this example, we said 4, making it really easy to come up with 1,500 patients per FTE. Down here, you can see that then we're going to use that 1,500 patients per FTE, and we're going to multiply it by visits per patient per year. This is not what we had on the other slide. This is, again, is a number that we put in here. We made that up. But that determines that you need 4,785 slots per year to meet the demand of your theoretical patient panel, right? And then you're going to look at supply. You're going to look at provider visits per day. That's your internal expectation of your providers. You're not going to find that in drives. You're also going to look at how many days per year your providers work. Again, you won't find that in drives either. That's going to be possibly individual per provider, right? So you have some providers who work less. They're, maybe a 0.8 FTE and they work less days. You have other providers who are full-time. So again, that's going to depend on your organization and how you calculate how many days a year that provider is going to work. So in this example, we're going to say we expect our providers to see 20 patients per day, and they work 230 days per year. And so they're able to provide 4,600 slots per year, which is less than what our ideal target panel would have them doing. And so in a case like this, then you need to start thinking about, okay, how do we get more access? Do we need to hire more people? Or do we need to look at our panel size, our target panel up here, and figure out a way to revise this? Do we need to require providers to see more patients in a day? So there are many ways you can use this information. Simple example, and again, I would direct you to Safety Net Medical Home or AAFP. They have spreadsheets that can help you with these calculations. But yeah, basically you need to figure out what's the difference between how many patients your providers are currently seeing and the number that they should be seeing. And in general, is one thing, and then down to the provider level adds a whole new set of complexities to the calculations. Okay. Once you have done those things, now you're ready to take action. I'm going to just kind of show you this slide real quick, and then I'm going to log into Drives, and we will look at the demo system. So first you are going to use, hang on everybody. You can use your usual provider assigned measure and the active to look at how many patients do not have a usual provider assigned. As you're cleaning up, you'll use your panel size measure to make sure that patients are put with the right PCP and panels are balanced. You'll use the continuity measure to see if any four-cut provider changes are needed. And as you continue this as an ongoing process, you can continue looking at your panel size measure and then your dashboard. So we're going to look at all of those things together right about now. So I'm going to go now to Drives. Again, I'm in a demo system. This is, you can see my screen, right? Yep, okay. I'm in a demo system and I just got to move my screens around. Thanks, everyone. Make sure I don't miss anything. Where we're going to go to see these measures is we're going to click on our measures icon over on the left nav. And in your library, you're going to scroll down to panel management. And you have 4 measures here. And so we're going to start with the bottom measure. This is going to be your usual provider assigned. We just want to check and make sure that everyone is actually assigned to a provider. In this case, it's 100%, yay, because it's demo data. But I do see that many health centers show 100% assignment. And so one thing you can do is just double check this by grouping your comparison chart by the assigned provider to make sure that there aren't any dummy providers there. So sometimes we'll see a provider named unassigned provider or unknown or something else that is not exactly an assignment, but they had to put something there. And so they made up a provider. And this one is going to help you look at exactly what % of patients are assigned to somebody. And then the patients, it says that we filter out unknown or unassigned provider. And I think we do try to do that, but I have seen it come across. So I would just double check. And then your denominator is going to be active patients who have had an encounter during the period with a code that is included in the face-to-face qualifying encounters. You can modify the trend line too if you would like to see a different period of time. And also you can change your baseline. Again, it won't make a difference here because we have had 100% provider assignment going back now. But that's a way that you can use this measure. now we're going to come to the panel size measure. And so what you would do is, again, referencing the usual provider assigned, you would take anybody who is assigned to a provider who's no longer here or assigned to a fake provider, and you would reassign them. And then you would come to your panel size measure and you would check, okay, how are panels going in terms of equity? You want the panels to be balanced. You don't want a particular provider to have way more patients than a different provider. And so we'll start at the top again. Again, this is going to be your count of active patients over your count of usual providers. And then you can see here, this is one of the few places where your default filter will be usual providers. And then you have a default active patient filter. So this is where I said you have the ability to pick a time frame that works for you. And so if I change it to the past 3 years and I click the update button, it will change that to look at that time period that I selected. And so what you can see here is that the average panel size is 226. But as I come over here, I can actually hover over these usual providers to get their actual assigned patient number. This is also a place where if you come to the detail list and you scroll out ever so slightly, you can see that recommended for-cut provider. And so we're going to look at that on a different measure, but it's here as well. You can also filter this to one particular provider. So say I just want to pick Dr. Augustine and I update it. So this is just going to list out all of Dr. Augustine's patients. Again, you have your recommended for-cut provider. And what I could do is select everyone except him, and then I get a list of people who might need to be reassigned. And if I come back over to my measure analyzer, it's going to update to show specifically the provider panel for Dr. Augustine. And then we'll just show him on the comparison chart. And then you could group this out by any number of things. For example, race. Any questions before we go on? Okay, now we're going to go to the provider continuity measure. This one's fun because we have 2 ways of looking at provider continuity. One way is from the patient perspective. The other way is from the provider perspective. This will do both of those things for you. This one has defaulted me to this period of June 2026. We're not even halfway through June. I also see I don't have any data for June. So I'm actually going to do a trailing year, May 2026 on this one so that I get some data. I'm in a demo. Your data is not going to look like this, or I hope it doesn't anyway. But that's one of the fun things about demo data. To see your patient perspective, you're going to come to this group by on your comparison chart, and you're going to put in the usual provider. Well, let's look at this to understand what that means. If I hover over Dr. Jane Doe, I see that there are 28 patients in the numerator and 240 patients in the denominator. And so, by definition, the numerator is going to be primary encounters where the rendering provider was the same as the patient's usual provider. the denominator is going to be the qualifying visits in the selected period. So pay attention to what you've selected for your grouper. This means that 240 patients who were assigned to Jane Doe as their PCP had visits with her. So from the patient perspective, the continuity is 11.7, right? So it's her panel of patients. They didn't necessarily see her. In fact, only 28 of them did. So remember that numerator. To see the provider perspective, I'm going to go to the grouper and pick rendering providers. Now we see Jane Doe is the third bar. That numerator is the same. There were 28 patients who were assigned to her and saw her over the past trailing year. However, the denominator is different. The denominator are the patients that Jane Doe saw. She was the rendering provider who provided the services. And so from that perspective, which is more, again, to the provider perspective, if I'm Dr. Doe, then I can see that 11.7 of the patients that I saw over the time period were mine. When you have these numbers, you can begin to consider, is that our goal? Is that what we want? Is that good for our patients? I'm in a demo system, so no, this is pretty terrible. You wouldn't want these numbers in real life. So take a look at what your numbers are telling you, and then you can go from there. Let me just see if there was anything else I wanted to say about that. Another way that you can view this is you can change that to a table view, and then you're able to, again, sort of the same thing. You can easily see, though, the numerator and denominator and make sure that they are pretty comparable. And then the last measure we're going to look at is the forecut. So again, come into your library and scroll down to panel management, and it's the first one in that group. So once again, we're in a demo system here, so just keep that in mind. But again, your default filter is going to be the usual provider filter and not the rendering provider filter. And so what this is telling us is basically at a practice level, 10% of our patients are assigned to the provider that the forecut calculation is recommending. And so again, check your trend chart for any significant peaks and valleys. And then you can use your comparison chart over here, again, to look at this in different ways. We can also, same thing, we can look at this as a table view to get a sense of the numerator and denominator. But the real meat of this measure is going to be in your detail list, where you can come in here, and I'm going to scroll out to the right until I get to the forecut assigned provider column, and you can see here who is going to be that recommended provider, and what is the method by which that provider was selected. And so this, I like to rearrange this a little bit, because you can see your usual provider is all the way over here. So I'm going to go back out to my forecut assigned provider. I'm going to left click and drag where it says forecut assigned provider. And I'm just going to drag it over here. I went a little bit too far, but that's okay. They're still right next to each other. What I wanted to do is, actually, that's okay. I split the usual columns, and so this is actually fine. But now the provider who's assigned as the usual provider is right here. The recommended provider is right here. So if you can see those right next to each other, then it kind of gives you a better sense. Another thing you can do is you can say, well, I'm just going to work on Dr. Winslow today. And again, you can come to this recommended column and you can select everybody but Dr. Winslow. And then you're able to see just those patients that should be reassigned. So we just have a few minutes left. I'll pause here if there are any questions or anything that happened in the chat that people want to bring up. Okay.
Hey everybody, this is Heather. I did pop a few things into the chat. I know across our network we have health centers that are on various different levels of working with panels from I'm not even sure what you're talking about to we've been working on it and we've used a amalgamation of different reports and things out of different places and I'm looking for better ways to do it. So wherever you are on that spectrum, hopefully something came out of this that's useful. This is something we've kind of been hearing at our level for a little while now that you guys are working on and looking for tools around. So we have planned that, after this, wraps up today, we will be available to help you wherever you're at, get started on next steps, or even just strategize where you want to start if this is something you want to start. So I know this has been a lot of really great information. Hannah, this has been wonderful. What I'd like for you guys to do now is kind of where did you get stuck? Did you have questions? Is there something that we looked at that we went through a little too fast that you didn't see where it was in the system? You can come off mic, you can pop that in the chat, and feel free, as ever, to throw us your questions 5 minutes after we close out because that is generally when my questions come to mind and I think of what I'm trying to ask. So, Hannah, back to you.
Okay. This is really the last thing I'm going to mention today as far as tools and drives. Um, this is kind of pulling it all together. So this is an example, right? You don't have to use this, but this is going to pull it all together in one place where you can kind of keep an eye on things. A dashboard is a great way to summarize that information and have it be ready for like a leadership meeting, a board meeting, etc., or even creating a dashboard that would help at your sites for your staff to understand what's going on, what do I need to work on, who are the patients that need to be reassigned, etc. And so on this one, again, a lot of this is based on measures that we have talked about today. And we did put in a few other things here, such as patients with primary care encounters in the period. So we're doing a trailing year, June 2026. Any blue number you can click on and get the details. Any title you can click on. It will take you to the measure. All right, so we've been here, and because we clicked here from a dashboard, we have this really handy arrow to go back to that dashboard. You can see this matches what we looked at when we looked at the four-cut measure, when we looked at our provider continuity, and you can see too that widgets will allow you to display a target on them. So that again provides for an easy visualization of, are we doing well on this? In our demo system today, as I mentioned, we're not doing super well on empanelment. You can see I don't have any interactions coming up because we don't have that mapped because our demo system does not support that right at the moment. But we can manage our, we can see our panel size. Again, in these smaller tables, a lot of times you can click on those numbers to get those details. So we could click on the 232 patients assigned to Dr. Winslow and get their details and download this if necessary. Same thing for these work lists. This one is formatted so you can see who needs to be assigned to Dr. Winslow, for example. This one is the opposite. This is telling you who should be removed from Dr. Winslow. We do have diagnoses over here, so you can kind of keep an eye on what are the most prevalent conditions that your patients have. And then I'll scroll down a little bit more because we just have, again, panel size by provider, and a general age distribution. This is going to be based on the panel size measure. Your risk distribution is also based on the panel size measure. You're going to build your widgets out of measures that exist. And then I'll come back over here to the bottom left where we have our continuity by provider. So this is just a way that you can pull this information together to present to a target audience, such as your board of directors or your leadership. I can see how you might want to create a dashboard for your staff, for example, that focuses on these measures related to the four-cut provider assignment and whether you want to do the assign version or the remove version. Again, it depends on how you set up those workflows, but that could be helpful for your staff just to have those along with the overall panel match and the provider continuity. So again, we'll send out the slides. I'm going to pause if there were any questions that came up or anything that we should address.
I don't see anything in the chat yet. Where we do have our survey in the chat, so if everybody could grab that link so they could complete that for us, that would be awesome. The what would be, let's see, Dylan would like to see if there's a way to look at the risk distribution by panel.
Sure. So I am going to go right here from the dashboard. The risk distribution, if I hover over the title, I can see it's based on this panel size measure. And so I can either go in through the measures menu and go back to the panel size measure, or I can actually click on the title of the widget. And it's hopefully going to populate with that risk over in the comparison table. Here it is, patient risk. And so right now it's set to be overall. How you would do this for a particular providers panel, once it populates, it's not going to populate.
You can maybe try to just go to that measure, search for it. Maybe that'll. There you go.
Patient risk. Okay, here we are. This is patient risk overall in your practice because I have it set to all usual providers. And if I want to see it by a particular provider, I can do it here. I can say, I just want to see it for Patrick Crowley's patients. And then I would need to reset my patient risk in this grouper. But if I do this, I'm going to click this full size, expand to full screen option. And now what I can do is I can actually open this control panel. I'm going to leave this on usual providers. And in my second grouping option, which is only available when you go into full screen mode, I'm going to put my patient risk, and it's going to update, and it's going to show me by provider, low, medium, and high. And then my Zoom window's in the way. Sorry about that. And then at the bottom, you would see this legend. If you want to, you can arrange it this way. You can arrange it as a table, although I don't like this table because there's, too many things going on. I think a column chart like this is appropriate, and then you could export it as an image or screenshot it. I tend to just do screenshots still. But if you needed it for some sort of publication, you could get it that way. I hope that answered the question.
I don't see a follow-up question, so I think that got to what he was looking for. Yes, that got to what he was looking for. One thing, as you guys are looking at the risk level, keep in mind that's a risk level. It's not necessarily a complexity level. And also, we will be looking at risk level stratification in the next year's work plan. And so that will be something that will be coming up. Also, in our next work plan, we will be looking at system maintenance and mapping, because it's something that has insidiously filtered itself in, and with as much robust data, measures, report, all of the things that we have available, it is critical to having that ongoing, continuous data governance and management. So we're going to be working on that in our year 2 work plan. So those are some of the things that are coming up. Does anybody have another question about what we've covered today, or something we've not covered today that you still have a question about?
Oh, let me show you one more thing. Though this is the result. So this is going to be the number of patients. I was going to see if it would show you a percentage. Sort by. That's just the same thing. And that's the providers. Okay, I'm sorry. Yeah, I don't have a way to show you the percentage of the panel right here in this measure.
Any other questions or thoughts come to mind on this or any other topics? And like I said, if you think of them right after you sign off, please don't hesitate to send those on to us. Those are really where we kind of get our guidance from on what we bring to you guys. And please, please make sure and grab that survey. We do need that survey not just to guide what we do in the future, but also for our HCCN reporting. I do see another question in the chat. Is anyone that is managing panels adjusting for risk, acuity, or severity? I'm not seeing anybody come off mute, but I do think that Health Ministries is working towards that. I'm not trying to call you guys out or throw you out into the deep end, but uh, that's some conversation that I've had.
Heather, will you repeat what you
Anyone?
just said? I'm sorry.
Dylan at Hunter had asked if anybody that was working on their panels was doing any adjustments or looking at acuity of patient panels. Um, and I know that we had kind of looked at how to look at risk stratification in looking at panels and how it's not risk isn't necessarily complexity, but it can kind of be an indicator of how complex they might be. So I know you guys had done a little bit of looking around that. I see Amy at Heartland has, they are looking at it with average visits per patient, so volume, demand more so than individual acuity, complexity. So there's several different ways to look at that. Um, this is a huge topic. It's one that we've not done a whole lot of work around that has been mentioned in passing by several different health centers, so it has definitely come to the top of mind. And really looking at how we can better support you. For those of you that are just getting started, or it's like, what are you even talking about? Or I've heard of that, maybe way back when we set up PCMH years ago and wanting to kind of get more info with that, you are in a perfect spot. Those of you that are working on it and trying to get your reports running, y'all are in a perfect spot. Everybody is in the perfect spot for where you are. We never are finished. There's always something new, different, changing. Our focus may change. So nobody is behind the game. Some of you may just be more skilled at using the tools that are in front of us, and we will lean on you as we work into this a little bit further. So, just really appreciate everybody coming, really appreciate your feedback and bringing this topic to mind. We'll look at this in our calls in July. I want to make sure that we have time to follow up on this. There is a lot of different things going on, and we can drill down to where you are in your health center. And it's not just July. That will continue on as long as there's support and help that we can do, not just me. We've got a whole team here. And Azara is also available for any follow-up
Absolutely.
questions, support, or where was that thing? How do we get there? Yep. Well, if we need to come up with some click maps on how to get to the different places, we can definitely do that. What questions do you guys have? All right. Well, we are at time. Thank you, everybody, for coming today. Please grab that survey link and give us some feedback on that. Hannah, thank you so much for this wealth of information. It was
You're
great.
so welcome.
And hopefully
Yeah,
I'll have
just
some follow-up questions coming back to you.
yeah, send them our way. Happy to be here. Thanks for spending your an hour of your afternoon with me.